This eHIV Review Special Edition program is presented by DKB Med Radio. Welcome to the continuation of this special edition of eHIV Review, focused on the needs of marginalized populations living with HIV. The multimedia expert commentary section has recently been published and is available without charge at eHIVreview.org. In that part of the program, eHIV Review Program Director Justin Alves, a nurse educator at Boston Medical Center, described the recent evidence-based findings in 1, the disparities in HIV care in underserved populations, and 2, identification and treatment of substance use in people living with HIV. Justin also reached out to 2 frontline clinicians currently working with these populations who provided additional commentary through short video clips. In this part of our special edition program, we'll be presenting the fuller video discussions for those additional experts. I'm Bob Busker, DKB Med Editorial Director and Managing Editor of eHIV Review. I'm here with the aforementioned Program Director, Justin Alves. Justin, thank you for joining us today.
I'm glad to be here, Bob. Thank you for having me.
Our first topic and our first learning objective is to identify the barriers that limit the participation and engagement of underserved populations in HIV prevention and treatment medication selection. In the multimedia part of this program, he spoke with Dr. Nicky Mehtani, a primary care physician specializing in addiction medicine and HIV. Before we get to the rest of that discussion, if you would please, tell us a little bit about Dr. Mehtani and why you chose to speak with her.
Well, I think it will be very obvious to folks why I chose to speak with Dr. Mehtani. She is not only a seasoned care provider, but she really has a passion for the work that she does. And she works out of a really unique street-based clinic, the Whole Person Integrated Care Clinic in San Francisco through the Department of Public Health. And she really specializes in the care of people who are experiencing homelessness and substance use disorder, and who are also living with HIV. And so really felt like the right fit to sort of shed some light on some of the novel approaches that they're using to engage these marginalized communities.
And with that as introduction, here's the rest of the discussion between Justin Alves and Dr. Nicky Mehtani.
Hi, Dr. Mehtani. Thank you so much for joining us today.
Thanks so much for inviting me. Happy to be here.
I'm so excited to sort of get into this, and I'm wondering if you want to start by telling us a little bit about the patient population that you serve and some of the barriers that they experience when they try and engage in care.
Yeah. So, like the primary goal of the clinic that I work at is to provide what we call transitional primary care to patients who are experiencing homelessness or unstable housing here in San Francisco, who, due to factors related to homelessness, are unable to engage in the more traditional models of primary care. And, we're a status neutral clinic, meaning that we see both people with HIV as well as patients who do not have HIV, although many of our patients without HIV are at very high risk and could benefit quite a bit from being on PrEP. And because we're lucky that we're in a city that has so many other phenomenal HIV primary care clinics, including some traditional primary care clinics that actually have specialized programs for people experiencing homelessness. The patients that we see at our clinic who have HIV represent probably some of the most vulnerable patients in San Francisco who've really fallen through the cracks of these other programs. And ultimately what that means is that in addition to homelessness or unstable housing, the vast majority of our patients also have comorbid substance use disorders, particularly methamphetamine and opioid use disorder. And many also have comorbid severe mental illnesses, such as schizophrenia, schizoaffective disorder, and bipolar disorder. The demographics, I think, of our patient population also differ considerably from others in San Francisco as a whole, both in terms of socioeconomic backgrounds as well as racial and ethnic backgrounds. Almost all of our patients are publicly insured, and a lot of them are actually uninsured when they first start seeing us. So we need to coordinate care with social work to help them get access to insurance. And all of these patient level factors result in barriers to HIV care engagement. But I think the most difficult barriers to manage are really related to lack of housing and mental health conditions. Again, including substance use. And no matter how good our medications are, we can't really expect people to take oral medications every day if they don't have a home and some sort of safe place to store their medications, especially when their tents and belongings are routinely being swept by law enforcement. But beyond the logistical issues of taking medications every day or even receiving injections monthly, our patients also just face a number of competing priorities, and the everyday kind of trauma associated with homelessness makes life really unpredictable. So managing their HIV is understandably not always going to be their highest priority if they don't know where they're going to sleep tonight, or where they're going to be able to find food to eat, or how they're going to manage to stay out of opioid or stimulant withdrawal.
And when you talk a lot about falling through the cracks, right? I mean, patients who are complicated, like you're describing, do you mean that they don't engage in traditional models of care, or like what is it that like makes yours sort of the sweet spot for folks?
Yeah, I mean, I think we're a very low barrier clinic, and so we're centrally located in an area of town where a lot of our patients might reside if they don't have housing. There's a lot of homeless shelters in the area. There's also areas of the city where there's more tent encampments. So just by being closer to them, that makes us lower barrier. But also we have a walk-in model. We call it an open access care model, where patients can come 6 days a week, 8 hours per day, 6 days a week, and see a doctor, see a nurse, get medications, get injectable medications, get oral medications, also see social work, get labs on site. So having all of this in a single location, and then also in addition to this kind of central hub, we also have what we call like satellite clinical sites that are embedded in, it's like a provider nursing duo, or maybe just a provider or just a nurse from our clinic or from our kind of overall network of care, embedded into places like a syringe access site or a homeless shelter, places that patients might already frequent, even if they're not searching for medical care, not necessarily care seeking.
So quite literally, like identifying those barriers and then just like bringing care to people.
That's the goal, yeah. And recognizing that, treating HIV in particular might not be the highest priority for some of our patients. Definitely preventing HIV might not be on their radar. So bringing them both the information as well as the way to have those things treated to them in as low barrier of a way as we can, without having to make them go to the pharmacy or go somewhere different for labs, trying to streamline it all in one location.
And you mentioned some of the different sort of medication options, talking about injectables, talking about new oral agents even. How do medication options really affect the way you think about choosing medications for patients, or even like, this patient has a lot of barriers to care, so I'm going to choose a medication like X, so to speak?
Sure. So, assuming that a patient doesn't have significant baseline resistance in terms of HIV, my go-to for any new patient with HIV that I see is to encourage that they use a single tablet oral HIV regimen, usually either darunavir, CoV, TAF FTC, or BIC TAF FTC. And I really try to encourage darunavir, CoV, TAF FTC as the first line, just due to a particularly high barrier to resistance. Because it's common that our patients will only be able to remember to take their medications 4 to 5 times per week, sometimes less. And I don't want to put them at risk for developing integrase inhibitor resistance in that setting. But it's also, darunavir, CoV, TAF FTC is a really big pill. It's a large tablet. So that can be a barrier for some patients. And so if they don't have regular access to water in particular, or they don't like swallowing pills, in those cases, we'd go with BIC TAF FTC, or something similar that's an oral tablet regimen. In terms of single tablet regimens that I try to stay away from, I really try to stay away from rilpivirine containing medications, just because the necessity to take that with food. Also abacavir, just given the lower barrier to resistance.
And, do you have thoughts about so rilpivirine and sort of the oral formulation, sort of concerns about food? Do you have those same thoughts with injectables?
Yeah.
So like the cabotegravir, rilpivirine combo there?
Yeah. So what I was meant to follow up with. So in addition to, we start with the oral meds. A lot of patients can't take oral meds for a variety of reasons, or they have trouble adhering to their medications, don't have a place to store their meds. So over the past 2 years, we've also developed a pilot low barrier, long-acting injectable ARV program. And we try to be really judicious with deciding who is appropriate for injectable antiretrovirals, because they've really never formally been studied in settings like ours, and in patients who have severe mental health comorbidities. And also because it's hard sometimes to contact our patients to remind them for when their injectables are due. And so we really want to make sure that when we do start people on injectables, we can make sure that they're coming in every month. In terms of your question about ropivacaine, injectable ropivacaine, do I worry about the oral, with oral ropivacaine, you need to take that with food. I think it's 350 calorie meal. And so previously we really kind of stayed away from that. Now, if a patient doesn't have any baseline resistance to RPV, that's great. We can at least they kind of satisfy that criteria for not for being eligible for cabotegravir or ropivacaine as an injectable. But in addition to kind of the medical reasons that somebody might be contraindicated for cab RPV, which are on kind of like the package insert, we also kind of particularly only use long-acting injectable ART for patients that are already kind of well connected to our clinic or one of our satellite clinics and know at least one or two of our providers well, so that they feel comfortable continuing to come back. We're not worried about that after somebody getting one or two injections and then not wanting to come back or not able to come back. And we also try to prioritize long-acting injectables really for patients who don't seem to have any other options, because they've demonstrated an inability to tolerate oral ART or to adhere to oral ART for a variety of reasons. And yeah, the reason for that is really we're kind of building the evidence along with a few other clinics who are doing very similar things. And we've learned from our neighbors over at Ward 86, who are an academic HIV clinic in our city, who kind of paved the way for this, but want to keep this focused right now and in a way that we can make sure that we're doing this safely and people aren't starting meds and then coming off of them immediately.
Well, and what it sounds like is that you really prioritize the patient rapport as the prerequisite for the injectable. Not like there is some science piece there, but there's also this like the requirement is I need to know you're going to come back, right, and get that injection with us.
Yeah, that's really critical. And we try to make this as low barrier as possible. We don't want them to have like XYZ criteria. The primary thing that we look for is people are motivated to start this, and they want to start this. And then once it's clear that they really want to start this on their own, it's not something that we're kind of pushing on them or anything. Then making sure that they have the resources available to them to make sure that they're actually able to continue to come into care. So, for example, if a patient really wanted to start long-acting ART, but we've only seen them once or twice over, the past year, we'd probably want to work with them, maybe connect them with case management, have them come to our clinic at least monthly for a couple of months, and then if it seems like they're able to engage with us, or we're able to locate them consistently in the community, then we can start transitioning them to long-acting. And sometimes the patient has a very low CD4 count and you have less time that you can really wait or that you want to wait. So I think trying to protocolize things, we do have protocols and we try to stick to them. But I think even outside of HIV care and outside of the injectable world, it can be hard to really protocolize things when we have such a diverse patient population.
Well, and I think that brings me to sort of my next question for you is there's a lot of focus about ending the HIV epidemic. And obviously, long-acting prevention medications, including implantables and injectables, have a role there. But I'm wondering, how can we truly try and start thinking about how do we use these medications in a patient-centered way, like you're talking about, with that flexibility to meet that need of a lot of our marginalized communities, because they don't necessarily fit in the box we'd like them to fit in, right?
Yeah, absolutely. So I think really to end the HIV epidemic, we really need to think about patients more holistically outside of just the scope of HIV care, because in a vacuum, HIV itself is actually not super difficult to treat. And we really need to focus much more on the upstream barriers to medication adherence and HIV transmission. including treatment and prevention of substance use disorders and mental health conditions. But taking a step back and focusing on what we can do more immediately as medical providers, and specifically as HIV medical providers, I do think that being able to offer marginalized patient populations more options in terms of access to injectable ART and future innovations in the pipeline, including implantables, could make a significant dent in reducing HIV transmission among some of our most highly affected communities, and sort of inching towards the ending the HIV epidemic. I will say that with implantables, I think I love the idea of implantables, and I think anything that we can do to lengthen the time interval during which patients are receiving therapeutic drug levels and having to reduce their requirements to come into clinic and get labs, the better, and that's helpful. But I also think we need more data to understand patients' preferences with regard to long-acting injections versus implantables. We have quite a few patients. We have some patients, I should say, on long-acting injectables right now. But I've also heard some patients say, implantables kind of feel more akin to some sort of like tracking device, and there can be quite a bit of pain and more injection site reactions with implantables. So I think we need to do a little bit more. We need to create a little bit more data on acceptability and tolerability of those agents.
Well, and really taking that patient-centered approach that maybe this is not the one for you, maybe this other. I think of it a little like contraception nowadays, of like there's so many different versions, right? Like which is the right one for you, right?
Exactly.
And so we've gone over a lot of different stuff, and so really trying to hone in on our learning objective about identifying barriers that limit participation and engagement of underserved populations in HIV prevention and treatment. I'm wondering if you have some takeaways for our listeners today, like a top 5 takeaway that we can give to folks to really drive home some of these points.
Sure. Yeah. I'd say, number one, in addition to HIV care, making sure that your clinic is set up to provide care for comorbid mental health conditions and substance use disorders. 2, when prescribing ART to patients who face adherence barriers, try to use single tablet regimens that have a high barrier to resistance whenever possible. Then we really do not yet have robust population level evidence for long-acting injectables in highly underserved patient populations at this point. But I do think that long-acting injectables are likely to provide meaningful benefits to reducing barriers to barriers to adherence to oral meds. And we do have patients who are doing really well on that right now. However, long-acting injectables should really only be started in the context of well-designed, highly supportive programs that ideally have the ability to provide things like mobile street outreach, reminders, and ways to contact patients who might not have access to a cell phone or MyChart or other ways that traditional clinics are contacting patients.
And so just a huge thank you to you, Dr. Mehtani, for being with us today and sharing a little bit of your know-how and knowledge straight from the clinic for our providers and listeners today.
Thank you so much. Thanks for having me. It's my pleasure to be here.
Fabulous.
Nice discussion. Justin, anything you want to add to her key summary points?
I mean, I really just want to reiterate a lot of what Dr. Mehtani said. It's about providing truly patient-centered care, right? She talks about meeting all of the needs of the patients who show up. So the mental health conditions, the substance use disorders, and the HIV all at once. Really being flexible and having a highly supportive program that can meet the needs of really vulnerable, marginalized populations with things like housing and things like, direct service support. And then really thinking about how we as a medical community can use some of the innovations we have, like long-acting injectables, single tablet regimens, to really, improve people's quality of life and really prevent resistance later on in sort of the development or progression of their disease.
Good observations, Justin. Going back now to your commentary issue, you explained how people living with HIV who use illicit drugs and those with substance abuse disorders, and those substances would include tobacco and alcohol, are a high-risk population. For an additional perspective, you called on Professor Vanessa Loukas from Boston University's Chobanian and Avedisian School of Medicine. Before we go to the rest of that discussion, if you would please, Justin, tell us a little bit about Professor Loukas and why you chose to speak with her.
So, I mean, Vanessa Loukas and I have actually worked alongside each other for quite some time caring for patients. And when I needed to think of someone who really understood what it meant clinically as well as academically to take care of folks with substance use disorder and HIV, she was the first person who came to mind. She practices in a primary care setting, but has also practiced in the community and really has a grasp on how to do this in a practical and pragmatic way.
Keeping in mind our second learning objective, describe strategies to improve identification and management of substance use in people living with HIV. Here's the rest of the discussion between Justin Alves and Professor Vanessa Loukas.
And I'm really pleased that we have Vanessa Loukas here to join me today to talk about addiction and HIV. Hi, Vanessa.
Hi, thank you for having me.
I'm thrilled to have you because I know you have a lot of experience with addiction and with HIV. And I'm wondering if you can tell our listeners a little bit about how addiction impacts your practice and impacts your patients with HIV.
My clinical specialty is to treat patients with substance use disorder and also those with chronic mental health issues in primary care. So I really started seeing patients with HIV secondary to that, actually. Patients with HIV were referred to me in the community health setting due to their comorbid addictions. So all of the folks I really treat living with HIV have an addiction as well, whether that be substance use disorder of one substance or multiple substances, which is often the case. The patient population that I see is very complex for that reason and requires not just a close provider-patient relationship, but also the support that we are able to offer often in our community or outpatient settings. So additional support from nursing, for example. A lot of the patients that I was seeing in the community may have been seen previously in a larger hospital setting by an infectious disease provider and found that some of the barriers to accessing care in that setting were really challenging. So to treat them in their addiction treatment program actually made a lot more sense because we could kind of do a lot of these overlapping like treatments and interventions at the same time. And that's really where I started my care for this population.
So really what you were seeing is people with HIV were being referred to you for addiction stuff, and then you were taking over sort of everything.
Exactly. So being referred really for addiction and then really seeing the bigger picture with patients and the complexity and all of these overlapping, whether they be acute or long-term medical problems associated both with having HIV and addiction, it was easier to treat them within our setting under the addiction sort of umbrella.
So more like becoming like that medical home and like starting to take care of patients and, oh, you need a refill of your ARVs or you need a refill of your buprenorphine all in the same spot.
Yes, exactly. And depending on the substances people are using, often really complicating their HIV related medical problems. So an example being like risk for oral thrush if someone is also, smoking methamphetamines or crack, right? And so really sort of finding that it was a better care model to use that like medical home or that nursing care manager model.
And so, I think I mentioned buprenorphine, you mentioned crack and meth, and I think a lot of people think about, illicit substances when we talk about addiction and HIV. I think probably from the beginning of the epidemic, that was sort of what it was, framed as, like people who used heroin were at risk for HIV. And so I'm wondering, how do you think substances that are maybe less stigmatized, things like alcohol, things like nicotine, are affecting your patients with HIV?
Substances like nicotine and alcohol are often, in certain ways, even more challenging to address because they are socially acceptable, but also the use of nicotine, whether that be smoking cigarettes or vaping, and then additionally using alcohol really increased in this population. So we're seeing a lot of folks using high volumes of alcohol, using nicotine products in large quantities. And so really increasing risks not only associated with other substances of use, but then additionally increasing, risks around challenges to adherence to ART and additional medical complications.
And so within your practice, are you like purposely tackling those sort of less stigmatized substances too, or are those things that often get forgotten, you think?
I would say as a newer provider, in my past sort of treatment pattern, I may have given less attention to nicotine and tobacco than I should have. Now, where I am as a provider, I find I talk about it actually quite frequently, almost at every appointment, and really trying to tackle it, really, especially as it relates to vaping and nicotine products, really trying to understand what products people are using, how frequently they're using them, and really trying to implement any sort of nicotine replacement therapies or smoking cessation supports for folks, because really those are the things that can lead to longer term complications as well. For example, like screening for lung cancer, right? And patients living with HIV, really living long, fulfilling lives. And so encountering some of these chronic medical conditions that we maybe hadn't seen in the past. So screening for something like bladder cancer or lung cancer becoming really important for someone with HIV, and also that has a long history of nicotine use.
And, earlier you sort of mentioned how your addiction primary care practice was becoming more of like a medical home. And we are seeing a lot of that sort of pop up in the literature. We write about this a lot, about how do we integrate care so patients don't have to receive siloed care in the same way. And I'm wondering if you want to comment on some of the integrated care models you've been a part of or that you see really effective in practice.
Two models really come to mind based on my clinical experience. The first being the nurse care manager model, which really uses nurses to extend access to care. So I can see a lot more patients as a provider and have really complicated patients that are coming in quite frequently, being seen by a nurse that can then help to carry out my plan and continue to reassess and provide those really important hands-on interventions that maybe as a provider I would have less time to do so. The nurse care manager model really lends itself to facilitating really beautiful care for folks that have HIV and comorbid mental health or substance use conditions. Additionally, I have used a lot of group-based care in my experience. So sometimes maybe specific to a particular population or a particular severity of a disease state, but generally providing group-based medical care that allows me to see a lot more patients at once. So for folks that are really stable, even that really just want to check in and have some of that peer support, group is fabulous for that. Additionally, for patients that I want to see all the time, like I really want to have my point of contact with them maybe every week, but as a provider, I don't have the ability to really have that person in my schedule once a week. Having group-based care really allows folks to have a touch point with me, whether that be for refills or for labs, which is particularly important for patients with HIV, or for additional STI screening. All of those things really work well in that group-based medical model. And then I would say lastly about group-based care, I really enjoy it as a provider and find that it really can become patient-centered in a way that sometimes an individual visit doesn't allow for that time to do so in like a 20-minute or a 15-minute visit versus like an hour-long group where I can really hear the barriers or the successes of my patients that are living with HIV that have substance use as well.
That's fabulous. And I think those are two models of care that like we use in primary care for other things, for things like, diabetes, that perhaps we could really sort of adapt and use more frequently in HIV care. And so that sort of brings us to the end of our time together, Vanessa. And I'm wondering if you could, for our listeners, really try and bring this down to a couple key points. What are the things folks really need to know about sort of identifying and managing addiction and HIV at the same time?
People living with HIV are at increased risk for substance use disorders across the board, which includes nicotine, alcohol, stimulants, opioids, really increasing challenges around viral suppression and managing additional medical complications. And that would be my first point. I would also say that identifying substance use disorders and implementing prompt intervention, whether that be medications or behavioral interventions based on a patient-centered care plan, is critical to improving management of patients living with HIV and managing other related conditions long-term. Lastly, I like to really highlight that due to the stigma associated with both conditions and the potential for prior negative experiences with the healthcare system, it is really important to approach assessment and treatment of this patient population with curiosity, empathy, and humility, really to build rapport and effectively engage patients in longitudinal care, and really implementing some of these other models like the nurse care manager or group-based interventions to support that.
Vanessa, I just want to give you a huge thank you sort of for being with me today and talking about this. I know this is an issue that is like near and dear to my heart and yours, and so I really appreciate you.
Thank you so much for having me.
Excellent in-depth conversation. Justin, anything you want to add to our key summary points?
I mean, I just want to reiterate again, a lot of what Vanessa said is that we need to be thinking about not just screening people with substance use disorder for HIV, but screening people with HIV for substance use disorder, and recognizing that substance use disorders, whether they be illicit substances or licit legal substances, are things that we have tools to both identify, treat, and manage, just like HIV. And so trying to use our relationships with patients to address stigma and really help them, take that first step in identifying that they have a problem and starting treatment.
Thank you, Justin. We're about to wrap things up now, but I want to give you the last word on the topic. So if you would, please.
I mean, thanks, Bob, for giving me a final chance to sort of say something here. I really think the thing that I want to drive home is that HIV is no longer a death sentence. And so all of the chronic health issues that we had worried about in marginalized communities for decades, for centuries, really, things like hypertension, things like substance use, are all now really becoming problematic for people with HIV because people are living, which is a great thing, right? And now what we need to do is really use our skills and our know-how from centuries of work and social influences and determinants of health to really try and maximize quality of life for people with HIV. And that might mean, thinking about how we use long-acting injectables or implantables more readily, both for HIV prevention and HIV treatment. And it may also mean really thinking about the way we incorporate HIV care into the clinical space and thinking about how we really give opportunities to people who have been traditionally marginalized by the medical system.
Nice summation. Thank you, Justin.
Thanks so much, Bob. I really appreciate the opportunity to be here and really the opportunity to sort of shed light on this really important topic.
And I also want to thank our guests, Dr. Nicky Mehtani from the San Francisco Department of Public Health and Professor Vanessa Loukas from Boston University's Chobanian and Avedisian School of Medicine. And our thanks to all our listeners who've made eHIV Review the go-to program for in-depth expert opinion. For eHIV Review, I'm Bob Busker.